Welcome, everybody. This is the Rotary eClub of Silicon Valley. Every week, we try to bring you stories that will inspire you to see new possibilities for serving your communities and communities around the world. We are part of Rotary International, 1.2 something million members in 34,000 clubs. And it is always our goal to inspire each other through service. Our motto is service above self. Our program today is a program that we are doing with Elizabeth Hancq of the Treatment Advocacy Center in Arlington, Virginia. She has loads of experience on possibilities related to how we can be of service to those who are dealing with mental health issues and homelessness in our communities, and we are excited to have her with us. So with that, I am going to hand it over to you, Elizabeth. Thank you for being here.
Yes, thank you so much for having me, and good afternoon, everyone. Thank you for joining me today to discuss some societal challenges and public policies in the United States regarding severe mental illness and learning more about what we can do to help fix some of these issues. As Paul mentioned, my name is Elizabeth Hancq. I am the Director of the Office of Research and Public Affairs at the Treatment Advocacy Center. The Treatment Advocacy Center is a national nonprofit dedicated to improving access to treatment for people with severe mental illness. We are different than many of the other mental health organizations because we are really the only national nonprofit with this laser-like focus on individuals with the most severe psychiatric diseases. We also differ in that we are funded solely by foundations and individual donations. We do not accept funding from hospitals or pharmaceutical companies. So we work in all 50 states and at the national level in passing and supporting policies and practices to improve access to treatment for serious mental illness. And this includes less restrictive commitment laws, such as outpatient commitment, which is known as Laura's Law in California, and we can talk more about in the Q&A later. So the Office of Research and Public Affairs was established in 2015, really with a goal to educate the public and policymakers about severe mental illness, as well as the psychiatric bed crisis and its consequences, which is what this presentation is about. We also conduct independent research on the impact of severe mental illness on individuals, families, and communities. Some examples of this work include some commonly known statistics, such as the fact that there's 10 times more people with severe mental illness in jails and prisons than in our remaining state psychiatric hospital beds, or the fact that people with severe mental illness are 16 times more likely to be shot and killed by police than people without mental illness. So what is severe mental illness? It impacts 3.3% of the adult population, or 8.3 million adults in the United States. Included in this definition is disorders such as schizophrenia or other non-affective psychotic disorders such as schizoaffective disorder, as well as severe bipolar disorder and major depression with psychotic features. Approximately half of these individuals receive no treatment in a given year, with a host of consequences on the individual's recovery, their loved ones and families, and society. A contributing factor to this high non-treatment rate is a symptom of severe mental illness itself called anosognosia. Anosognosia is also referred to as lack of insight and is experienced by approximately about half of people with severe mental illness. So anosognosia impairs a person's ability to understand and perceive their illness. And it's important to note that it is not the same thing as denial or stubbornness or some other unwillingness to accept one's condition. In fact, there's underlying brain changes that can happen in individuals with anosognosia. You can see on the slide here functional MRI images of people with schizophrenia with and without insight. So the general public more commonly understands this construct of anosognosia for individuals who have experienced a stroke or those with dementia. For example, if you've ever had a loved one that is suffering from Alzheimer's disease or dementia, they sometimes do not have an ability to understand what is happening to them or that something is not right. Severe mental illness is a treatable condition, but if you can imagine, as would be the case for any person, if you're unable to understand that you have an illness or believe that you need treatment, seeking treatment or accepting treatment as prescribed, where understanding the need for treatment is extremely challenging. Now, unfortunately, public policies in the United States have been created over the past 60 years or so without an understanding of the complexities and nuances of the disorders around serious mental illness. So deinstitutionalization is a phrase that refers to the emptying out of the largest asylums housing people with mental illness, which reached their peak number in 1955. There are a variety of factors that played into the emptying out of the asylums, including the conditions of the hospitals themselves, as well as the discovery of antipsychotic medications. But a large contributor of the emptying out of the asylums and the loss of state psychiatric hospital beds is the economics. So there is a shift from state to federal funding with the passage of the Community Mental Health Act by President Kennedy, as well as the Social Security Act that established Medicare and Medicaid in 1965. Now, when Medicare and Medicaid was established, it included in the law was a provision to exclude Medicaid coverage in mental institutions with more than 16 beds. And this is referred to the IMD exclusion and still exists in our law today. However, there are some new opportunities for states to apply for waivers to this law, which we can also talk more about later in the Q&A. Part of President Kennedy's interest in mental illness is due to his sister, who's pictured here, Rosemary Kennedy, who developed a psychotic disorder at age 21 years old. So the ideal behind the deinstitutionalization movement was fundamentally sound. Most patients with severe mental illness can live safely outside of a hospital with adequate supports in the community. As I mentioned, for most people with severe mental illness, recovery is achievable and many people go on to live successful and fulfilling lives. The problem is that the execution of the deinstitutionalization and the associated public policies developed did not prioritize the treatment of people with severe mental illness and those coming out of the state hospitals. And although this is just a cartoon, the reality is that the resulting fragmented mental health system is in fact not saving any money at all. It's tremendously more costly. As a result, 60 or so years later, we have 3.5% of the state psychiatric hospital beds that we once had in 1955. Now, this data was last updated in 2016, which was in fact my first research project at the Treatment Advocacy Center, but all evidence points to even more bed losses in the 4 years since then. It is really important to look at the types of beds remaining as well. Almost half of the remaining state hospital beds are designated for forensic patients or those involved with the criminal justice system. This includes competency to stand trial or for those found not guilty by reason of insanity. In California, 3/4 of the remaining state hospital beds are for forensic patients. And that doesn't even include the multiple hospitals that California includes in their bed count, but that we do not, because these hospitals are operated by the Department of Corrections and beds that we refer to as beds behind bars. So really there's this preserved incentive structure to criminalize an illness in order to get people into the system, whereas perceived as a way to receive mental health treatment. The United States has one of the lowest number of psychiatric beds per capita than any other industrialized country. So you look here at the graph of the OECD. The OECD average of psychiatric beds per capita is 71, whereas the United States has 22 beds per 100,000. This 22 number includes state hospital beds, private psychiatric hospital beds, as well as beds in psychiatric units within general hospitals. In a functional mental health system, inpatient care is one of the essential points in the continuum of care for psychiatric treatments. Without an adequate service capacity, the care of these individuals have fallen to public service systems that can't say no, such as our criminal justice system and emergency departments. I love this picture taken by a colleague of mine because I really think it depicts the reality of receiving mental health treatment in the United States. Law enforcement have become the de facto frontline mental health crisis providers and are the ones that transport people in mental health crisis to treatment. And in part because of a lack of psychiatric beds, law enforcement officers have to wait with these individuals in crisis and emergency departments for days and sometimes weeks for a bed to become available in a phenomenon known as psychiatric boarding. So the consequences of not prioritizing severe mental illness are profound. Without a full continuum of psychiatric care in the United States, acutely ill individuals deteriorate and present to local emergency departments, resulting in a fragmented treatment and enormously costly services and inefficiencies. Approximately 1/3 of those who experience homelessness on any given day are suffering from a severe mental illness. And people with severe mental illness who are homeless are more likely to be chronically homeless or on the streets. These issues are seen throughout the West Coast, especially in San Francisco, San Diego, Seattle, Portland, and in some of these areas, the prevalence of severe mental illness among the homeless is even higher. As I mentioned, severe mental illness and law enforcement have become the de facto mental health crisis providers, and in response have turned jails and prisons into the new asylums. Individuals with psychiatric diseases such as schizophrenia or severe bipolar disorder are 10 times more likely to be in a jail or prison than a hospital bed, and people with serious mental illness are 16 times more likely to be shot and killed by police in a law enforcement encounter than people without mental illness. And this is really in large part due to their increased likelihood of having an encounter with law enforcement in the first place. Therefore, there is a vital need for a full continuum of psychiatric care for people with severe mental illness, just like exists for those with other medical conditions such as heart disease. Individuals with mental illness have symptoms that wax and wane over time and need the appropriate level of care that meets their current status. A full continuum of psychiatric care consists of inpatient beds when an individual needs that level of support, as well as residential treatment, day hospitals, supportive employment, integrative collaborative primary care, among a host of other services. What I want to leave you with is what you can do as public citizens to help improve the lives of our fellow Americans suffering from serious mental illness. First, I publish a weekly research blog that aims to bring knowledge to people about some of these issues. Second, we really rely on grassroots advocacy in local communities to bring the change to some of the policies that we promote. We're always looking for advocates who are willing to contact local policymakers for support legislation. And third, if you're able, donating to organizations that help improve the lives of people with serious mental illness, including local service providers, can really make a world of a difference. And with that, I would like to turn it over to Rushton to answer some of your questions.
Wonderful, Elizabeth. Thank you so much for the presentation. We do have questions that are starting to line up, but I would also like to introduce the people that we have on the call. So as I call your name, please wave at the camera just to say hello, and that works well. So Carol in San Jose is a licensed marriage and family therapist. Thank you for being with us, Carol. My name is Rushton. I'm going in the order that they appear on my screen. My name is Rushton Hurley. I am a past president of the Rotary eClub of Silicon Valley and an educator. In Houston, we have Rory Olson, a member of our club and a former judge and an all-around interesting guy with a wonderful cat, right? We have also, let's see, Cindy McCalma, a pastor in Santa Clara County and also with the North American. Actually, I'm getting the words for NAMI incorrect for mental illness, but I'll have that corrected soon enough for sure. We also have Paul Bowen, an advocate for those who are homeless and facing mental health issues. We have Mary Hancq with us, a retired librarian from the city of Santa Clara. We have also Cecilia Babkirk, a member of our club, a retired business person and a Peace Corps volunteer. We have Farheen Awasi, right, who is in Santa Clara. She is a member of our club, our membership chair, and also wielder of a master's degree in reproductive biology from the University of Osaka in Japan. And then also off camera is Rosa Baum with the San Jose Unified School District. It is a pleasure to have all of you with us. Thank you for joining for this important conversation. So we're going to start with Farheen, who has a question. So Farheen, if you'll unmute and ask your question, and next after Farheen will be Paul.
Absolutely. Hi, Elizabeth. Thank you so much for your presentation. I found it really fascinating. As someone who really, I'm really fascinated by what's happening in our country in terms of mental health. I actually just applied to medical school, and while, you know, as Rushton mentioned, my focus is reproductive health, mental health. I mean, I am a believer that, you know, mental health is just as important, if not more important, than physical health. And, you know, you have to have both of them like perfectly balanced in order to be healthy. So I really appreciate your presentation. And so I guess my question is, are there any countries that have really strong mental health programs that can kind of be, you know, I don't know, models for the US?
Yes, that's a great question. And I think it's also important to note that there are places within the United States itself that do have good systems of care for people with serious mental illness as well. They're very common, and especially in California, people look to a model of mental health treatment in Trieste, Italy. It is a model of care that really emphasizes community care, but they do actually also have inpatient levels of care as well. And it's similar to this program that I very much am fond of, called the Clubhouse model for people with serious mental illness. The original model is in New York City called Fountain House, but there are 300 or so clubhouses throughout the world. And it's this basically like this day program for people with serious mental illness. It builds a sense of community, and it's really been impactful for people with serious mental illness. And Trieste has that similar sort of foundational philosophies.
Great, thank you.
Paul has a question that he added to the chat, asking if you had mentioned the IMD exclusion in your presentation. Are there groups in California that are seeking to attain a waiver for that exclusion?
So I know of a few local advocates actually in Contra, Costa County, California. They're mothers with sons with severe mental illness that are really powerful advocates in California to improving access to treatment for people with serious mental illness. And they recently published a paper looking at the status of more residential treatment options in California, and are really sort of taking the lead on applying for working with the state in applying for an IMD waiver. So the IMD waiver needs to be applied for by the state Medicaid agency, and in some states the legislator actually has to approve it as well, and so they're sort of taking the lead on that advocacy work.
I wonder, Elizabeth, if they would accept any help from people outside of Contra Costa County.
Oh yes, very much so, yes. And in the resources page that I provide to you, I'll include their contact information. I already reached out to them, letting them know that I was speaking to you all, and they were more than eager to have some new contacts.
And then just a follow-up question, how many states have a waiver to the IMD exclusion? And maybe just a short little summary of what that means.
Yes, so the IMD waiver is a demonstration opportunity through CMS, the Center for Medicaid Services within the federal government, that allows fee-for-service payment for Medicaid recipients in these hospitals that have more than 16 beds. As you can imagine, it's really financially challenging to provide these specialty services in a hospital with less than 16 beds, and due to the level of expertise and specialization required. And so the waiver opportunity allows these hospitals to apply and receive payments for Medicaid beneficiaries in these hospital systems. And so it's a demonstration. So it's more of a, it's approved for a year or 2 year to see, and requires some data to see if it works or not. And then hopefully, we're advocating for a full repeal of the IMD exclusion eventually. There are currently, and which is what's great about it, the 3 states plus Washington, D.C. that have received a waiver through CMS are also the only 4 places that we know of that have applied. And Iowa is considering applying and working on their application right now as well.
Can I just ask you, are the Contra Costa ladies, are they actually applying for that particular exclusion of IMB?
They are trying to advocate the state to apply, yes.
Okay.
The state Medicaid agency needs to apply for the state of California.
Thank you.
You're welcome.
Now we have a question from Cindy, and Cindy, I'll let you give a little bit of background to the author and book that you have the question about.
Yes, thank you. And thank you, Elizabeth, very much. My question has to do with community engagement. Obviously, what you are helping us to see is how we advocate on behalf of people with severe mental illness, but also in terms of how we engage. And I was wondering, one thing that we refer people to a lot is Dr. Xavier Amador's book, I'm Not Sick, I Don't Need Help. And I wondered how you felt about that, or just ways in which we can also be engaged with people themselves, wherever they are in treatment and recovery.
Yes, that's a great question. And that's a great book. Whenever I get asked the question, I always refer people to Dr. Amador's book as well. And so I think from my perspective, the more we all know and learn about these illnesses themselves, the more we're able to understand. And so it's really important for us as citizens, and even especially for those that are working directly with people with severe mental illness, to learn as much as they can about the illness, and especially learning from people with severe mental illness. So there's this great YouTube channel called Living Well with Schizophrenia, and this woman, Lauren, that publishes videos around just, a variety of topics, but she has one video in particular about anosognosia that is just excellent.
Thank you.
So Elizabeth, as we talk about the idea of helping people, not just systemically, but individually, if we know people who we think might be having challenges with regard to mental illness, are there standard things that people can say or do that can be useful, especially for those suffering from anosognosia, and just having that challenge of being able to say, I have an issue? Is there something we can do that on an interpersonal level that's useful?
Yes, that's a great question, Rushton. I think actually the local NAMI chapters are really a great resource for people, in both to learn more themselves, and they have these family-to-family programs and other educational resources that really help to understand the illness and how to interact with people, and maybe, as Cindy was referring to, how to engage people and to treat and depending on where they are in their sort of course of their treatments. So I think familiarizing yourselves with the local NAMI is a really important step. And then also, as I said before, and I think I just reiterate, the more we know, the more that we can do. And so taking it upon ourselves to learn and to educate ourselves, educate our families, the more that we can help.
Excellent, thank you. So for those watching the recording, NAMI, N-A-M-I, the National Alliance for Mental Illness, and you can find them at nami.org. We will have several of the different resources that Elizabeth has mentioned, including her organization, identified in the links below the recording on our program page. We'll wind things down, hand it over to Elizabeth for a final word, and then for all of you who are joining us for this recording, we'll stay and continue talking, because even though we've stopped the recording, it's a chance to continue the discussion. One of the things that we love about being part of the programs team for our club, and we invite all of our members to join us whenever they can. So visiting Rotarians, we hope that you will let us know you are here. There is an attendance piece just a little bit down the page where you can indicate your name, your email address, and by typing in your email address correctly, you'll get an email from us that you can pass along to your club secretary for to make up a missed meeting for your own club. A little farther down, you'll also see the discuss section. That is our forum for talking about what we learn in the presentation, and also from other parts of the meeting. So we hope that you will share your thoughts there and reply to the thoughts that other people have there as well. It's our chance to interact in our asynchronous system. So we welcome your thoughts there as well. As we always do, we'd like to hand it over to our speaker for a final word. And Elizabeth, I put it in your hands.
Yes, well, thank you so much, Russian, and thank you again to everyone for having me today. I'd like to leave you with just one point, in that a full continuum of psychiatric care is needed to treat people with severe mental illness, and inpatient care is a vital component of that. And until our public policies in the United States address the nuances of the disorders around serious mental illness, I think we'll continue to see some of the consequences that we're seeing today. So thank you very much.
Thank you, and everyone else, we will see you next week.